Welcome back guys. Now in this video let's discuss about intestinal cancer. So what's the most common intestinal cancer? The most common intestinal cancer is adenocarcinoma. Adenocarcinoma of what? Adenocarcinoma of colon. Okay, it's a adenocarcinoma of colon is the most common intestinal cancer. Now who can get this adenocarcinoma of the colon? Same risk factors. What are the risk factors? The risk factors are, the number one risk factor is smoking. Okay, so usually the intestinal cancer is going to be seen in the old age people somewhere around 60 years, and these old age people who are having these risk factors, especially smoking, alcoholism. Okay, next low fiber diet, very important, low fiber diet, and high fat consumption. Next, if these people are having something like familial adenomatous polyposis, syndromes like familial adenomatous polyposis because of the APC gene mutation. See, if there is a familial adenomatous polyposis, then they will definitely develop the colorectal cancer. They will definitely develop the colorectal cancer before 30 years. No need to wait till 60 years. Before 30 years, definitely they are going to develop the colorectal cancer, adenocarcinoma of the colon. Next, syndromes like HNPCC, which is also called as Lynch syndrome. HNPCC means hereditary non-polyposis. There are no polyps, Without polyps, colorectal cancer. Hereditary non-polyposis colorectal cancer. So these patients who are having hereditary non-polyposis colorectal cancer, apart from colorectal cancer, apart from colon cancer, they will also develop ovarian cancer. Next, endometrial cancer. Okay, ovarian cancer will be there, endometrial cancer will be there, that's a uterine cancer, along with this colon cancer. Okay, just now we have discussed colon cancer. These three things are going to be there in HNPCC syndrome. Next, who else are at risk? See, the patients with inflammatory bowel disease. So what are the inflammatory bowel diseases that we have discussed? The two inflammatory bowel diseases that we have discussed are, one is Crohn's disease and ulcerative colitis. So those patients who are having Crohn's disease and ulcerative colitis, they are also at a risk of developing colon cancer. Okay, the adenocarcinoma of the colon, mainly it is seen with the ulcerative colitis. Ulcerative colitis more, okay, more so the colon cancer is going to be seen with ulcerative colitis. So inflammatory bowel diseases are also a risk factor. Now see, this is what is important. See, the patient is having colitis. Okay, let me show you a table which is very important. See, colitis associated, the person who is having ulcerative colitis, they are at risk of developing colorectal cancer. Or the colorectal cancer can be sporadic also. It can be seen in a general normal population who is not having any risk factor. It can be sporadic, or it can be colitis associated, that is ulcerative colitis. Now what the important differences that you should know here is, see, this is the questions which were previously asked in the PG exams. See, colitis associated colorectal cancers are seen in younger population, younger age groups, but usually sporadic are seen in older age groups. So the person who is having colitis, now he develops the cancer that's going to be multifocal. Multifocal means in multiple places. Okay, many cancers are going to be seen. But a patient who is developing a cancer, that the colorectal cancer, in sporadic cases, is going to be a singular. So what are the important differences which I want you to know? Colitis associated cancers are going to be seen in much younger population. They are seen more proximally, and they are going to be multifocal. And not only that, see, what are the gene mutations which are associated? The gene mutations are early p53 gene mutations and late APC gene mutations. See, APC gene mutations are later on APC gene mutations will come. First, it's the p53 gene mutation. See, what we have discussed in the colorectal cancer, see, in the sporadic cases, it's the early APC gene mutations are seen. APC gene mutation is also going to cause familial adenomatous polyposis. Don't forget about that. Okay, so early APC gene mutations are seen in colitis associated ones. It's the early p53 gene mutations. Early p53 gene mutations are seen in colitis associated ones. Early APC gene mutations are seen in sporadic ones. Exactly opposite things. It's the late APC gene mutations seen in colitis associated, and late p53 gene mutations are associated with sporadic. Okay, the gene mutations, at the end of the day, both APC gene mutations will be seen as well as the p53 gene mutations are seen. Okay, both this APC gene mutation, p53 gene mutations can cause the colorectal cancer. Okay, but when? Early, late. Okay, that thing you should know. And see this histology. Histology is also important. In colitis associated colorectal cancer, there are more signet ring cells. Okay, there are more signet ring cells, more mucin production. More mucin production is there. More mucin. See, adenocarcinomas, right? Colorectal cancer. It's the most common cancer is adenocarcinoma of the colon. So more mucus production is going to be there. Because of that, the cells will look like a signet ring. I will show you the cells also, signet ring cells. But here they are rarely mucinous. Okay, in this variety they are rarely mucinous. They are well differentiated. Here poorly differentiated. So what I want you to know is only one point. The person who is having inflammatory bowel disease or colitis, okay, ulcerative colitis, where the person is going to have the pancolitis. So the patient who is having colitis can also develop the colorectal cancer. They will be multifocal. Early p53 gene mutations are seen. Highly mucinous. Signet ring cells are seen in younger groups, younger populations. Okay, so these are the important points which I want you to know. So after this, look here. See, there are multiple gene mutations which can lead to, okay, which can lead to the carcinoma. This is called as adenoma carcinoma sequence. First, adenoma is going to be there. I said you adenomatous polyps. They will turn into cancers. More likely they will turn into cancers. Adenomatous polyps will turn into cancers. Okay, so first normal, everything is normal, sir. Normal epithelium, everything is normal in the colon. First, it will get the APC gene mutation. So first you are going to have adenomas. So more and more mutations will accumulate. So first APC gene mutation, followed by BRAF or KRAS gene mutations, followed by SMAD4 gene mutations, different gene mutations, followed by TGF BR2 mutations, okay, p53 gene mutations. See, because of the accumulation of different types of mutations, the adenoma, the initial adenoma is going to convert into carcinoma. This is called as adenoma carcinoma sequence. Now, what are the important gene mutations that can lead to the transformation of the adenoma into the carcinoma? The important gene mutations which I want you to know is APC gene mutation, p53 gene mutation, APC gene mutation, p53 gene mutation, and also remember KRAS gene mutations. They can turn an adenoma into carcinoma. Okay, one important point is, see, look here, take a note, the important questions will come. Which is more important in the prognosis? Okay, what is more important in the prognosis of the colorectal cancer? Is it the staging or grading? Staging or grading? Grading means well differentiated, poorly differentiated. Staging means stage 1, stage 2, stage 3, stage 4. The staging and grading also I will discuss. Staging means where the cancerous cells are, whether there is metastasis, only mucosa is involved, submucosa, muscularis, serosa is involved, lymph nodes are involved. That's the staging. Stage 0, 1, 2, 3, 4 stages. What is grading? How the tumor cells are. They are well organized, differentiated or poorly differentiated. That's the grading. So what is most important in the prognosis of the tumor? Is it staging or grading? Staging, very important. Staging is important for prognosis, not the grading. Staging is important for the prognosis. Okay. Now look at this question. Now a 60-year-old man, old people are at risk of colon cancers. 60-year-old man found to have 5 centimeters exophytic mass in the ascending colon. See, now where is the cancer? Now the cancer is in the ascending colon. Now the tumor is in the ascending colon. Okay. During a screening colonoscopy, while going for the screening colonoscopy, the mass is found. Okay. Biopsy of the mass shows adenocarcinoma. It's established, biopsy, established, histologically established that this is a cancer. Okay, adenocarcinoma where? In the ascending colon. This is important, guys. See, now imagine this is the colon. Here is the tumor in the ascending colon. If the tumor is in the ascending colon, the symptoms are going to be different. If the tumor is in the descending colon, then the symptoms are going to be different. Okay. Now look here, the patient has no personal or family history of malignancy or colonic polyps. It's a sporadic case. There is no history. His medical problems include hypertension and he does not use any alcohol or tobacco. CT shows that chest and abdomen reveals no metastatic lesions. In the CT there is no metastasis. It's confirmed in the lungs or liver. A right colectomy is performed. Okay, right colectomy is performed. You have removed the colon. Right side colon. Gone. The presence of which of the following indicates poor prognosis? Presence of which of the following indicates the poor prognosis? Now let's see the answers. Abundant, well formed glands in the tumor. more the number of glands in the tumor, is it a bad prognosis? No. Cytokeratin expression in the malignant cells. Malignant cell invading the lamina propria means the cancer is now metastasizing into the lamina propria. Okay. Prominent lymphocyte infiltration to the tumor. The lymphocytes are infiltrating into the tumor. Inflammatory cells are there in the tumor. And tumor cell deposits in the regional lymph nodes. Tumor cells are metastasizing to the regional lymph nodes. Now, what you should know here is, look here. See, first there is a tumor cancer. See, the cancer is within the mucosa only. Only the cancer is present in the mucosa. See, that is called as a stage 0. It is not just like a polyp. Now, in stage 1, the cancer is going into the submucosa. In stage 2, it is infiltrating the mucosa also. The muscles are getting involved. In stage 3, infiltration of the serosa. Serosa is also involved. The mucosa, submucosa, muscularis and serosa. Serosa, till serosa the cancer is spreading. Now, in stage 4, there is the regional metastasis to the regional lymph nodes. Lymph nodes are also affected. See, now more the stage, more the cancer, more the, the risk, I should say bad prognosis. Okay, more the stage, bad prognosis. More the stage, bad prognosis. ఇక్కడ U world అని కనిపిస్తుంది కదా, ఇక్కడ U world అని ఉంది కదా, వీలైతే దీని మీద ప్యాచ్ చేసేసేయండి. ఓకే, U world అని కనిపిస్తుంది కదా, దాని మీద ప్యాచ్ చేసేసేయండి. ఓకే, వైట్ కలర్ ప్యాచ్ రావాలి ఆ U world అనే దగ్గర. ఓకే, కదిలినా కానీ ఎన్నిసార్లు వచ్చినా అక్కడ U world అనే దాని మీద కనిపించకూడదు. ఓకేనా, చిన్న చిన్న ప్యాచెస్ పెట్టేసేయండి. ఓకే, ఫాస్ట్ కదిలిపోయినప్పుడు నో ప్రాబ్లం, బట్ ఇలా ఉన్నప్పుడు ఆ U world అనే దాని మీద ప్యాచ్ పక్కా రావాలి. అదొకటి గుర్తుపెట్టుకోండి. జస్ట్ కంటిన్యూ. So, more the stage, bad prognosis. So, look here. So, which of the following options is going to show the bad prognosis? See, it's the tumor deposits in the regional lymph nodes, means stage 4. So, the prognosis depends on the stage. Stage 4, if the patient is having regional metastasis to the lymph nodes, that indicates the bad prognosis. So, the answer is here. See, prominent lymphocyte infiltration into the tumor. If the lymphocytes are getting infiltrated into the tumor, that's actually good, because the immune system is active, the immune system is recognizing that this is a tumor and attacking the tumor. That's actually good. That's actually good sign. Malignant cells invading the lamina propria. Okay, the malignant cells are going into the lamina propria of the mucosa, means metastasis. That's also a bad, but this is more stage, right? This is the stage 4. This is the wrong answer. This is the right answer, I should say. Okay, bad prognosis. Now, after this, let's look at this question. Okay, let's look at this question. A 65-year-old woman comes to the office after finding blood in her stool. There is a 65, again older woman, blood in her stool. She is physically active and exercises regularly. She is doing normal regular exercises. She does not use tobacco or alcohol. She has no history of peptic ulcer disease. Okay, her physical examination is unremarkable. Colonoscopy reveals large adenomatous polyps with severe dysplasia. Okay, severe dysplasia is there. Okay, in sigmoid colon. She undergoes resection of the sigmoid colon. We have removed the colon, and her carcinoembryonic antigen. Okay, carcinoembryonic antigen is levels are normal. Now, what is this carcinoembryonic antigen? I will discuss later. It's a tumor marker, sir. It's a tumor marker for the adenocarcinomas. So, carcinoembryonic antigen levels now became normal. The patient is interested in decreasing her chances of developing new polyps. Now she is saying, like, she is little worried, and she came to the doctor and she is saying, sir, just give me some medication which will decrease the chance of getting future polyps and future cancers. Okay, the physician discusses exercises, health, weight management and dietary factors associated with the reduction in the colon cancer risk. So, like taking less amount of fat, taking high amount of fibers, okay, doing regular exercises, so they will all decrease the risk of colon cancer. Okay, including decreasing fiber, yeah, this is what I have discussed, including increased fiber intake and reduced consumption of the refined sugars and fat. Which of the following enzymes could be inhibited with the medications? The medications that's going to be given by the doctor, it will inhibit an enzyme. If you inhibit that enzyme, you can decrease the chance of cancer formation. Okay, so which of the following enzymes could be inhibited with the medication to further reduce the patient's risk of developing recurrent adenoma? Okay, so to understand this, you just try to answer them, but it's hard for you to answer it. See, actually what you should know is, look here. Okay, look here. ఇక్కడ కూడా ఈ స్లైడ్లో కూడా దీని మీద ప్యాచ్ పెట్టేసేయండి. ఓకే, ఈ ఏరియాలో ప్యాచ్ రావాలి. ఓకే, నేను కదిలించాను, అందుకే ఇక్కడ ప్యాచ్ పెట్టేసాను, జస్ట్ స్టిల్ ప్యాచ్ పెట్టేసేయాలి. కంటిన్యూ. సో హియర్ ఇన్ దిస్ image what you can see is, guys look here, see what you are seeing here is the adenoma carcinoma sequence. I have already explained you that first the p53 gene mutations, KRAS gene mutations, APC gene mutations are going to occur, which will turn a normal epithelium first into the adenoma. Adenoma will be later converted into the carcinoma. What you should know is, in a patient who is having adenoma carcinoma sequence, it is observed that the cyclooxygenase 2 enzyme is over functioning. The cyclooxygenase 2 enzyme is over functioning, and that's also one of the important event in the turning adenoma into carcinoma. Okay, adenoma into carcinoma. So in adenoma carcinoma sequence, the cyclooxygenase 2 genes are over functioning. So now what you should do is, you can inhibit this enzyme. If you inhibit this enzyme, if you inhibit the action of the cyclooxygenase 2, the adenoma carcinoma sequence, or first the formation of the adenoma will be decreased. The chances of turning the normal epithelium into adenoma decreases. So answer is COX inhibitors, especially like aspirin. Aspirin is a COX inhibitor, so drugs like aspirin can be used. Okay, so what is the answer here? The answer is cyclooxygenase 2 should be inhibited. Okay, now after this, what else I should teach you? See, what are the clinical features? I have said you, if there is a cancer in the ascending colon, the clinical features are going to be different. If there is a cancer in the descending colon, then the clinical features are going to be different. So what are the differences? See, if there is a carcinoma in the proximal colon, especially in the ascending colon, see, these cancers are going to be exophytic in nature. Exophytic means they will, for example, see, imagine this is the ascending colon. Ascending colon is going to have a large caliber. It's going to have a large caliber. So the cancers will grow something like this. Okay, cancers will grow, but still, ascending colon caliber is more. Ascending colon caliber is more, sir. That too, in the ascending colon, most of the the feces, it's more in liquid form. It's still more water is there, so more liquid form. So usually it won't cause any obstruction. Though the tumor is large, it's an exophytic mass, the stools whatever were there in the colon, they are more in liquid form. So there is no obstruction. Usually there is no obstruction. Most of the time, see, these cancers which are present in the proximal colon, they will bleed. Okay, so they are ulcerative type of cancer. Most commonly they will cause chronic bleeding that will result in iron deficiency anemia. So cancer which is present in the proximal colon is going to cause iron deficiency anemia, and a cancer which is present in the distal colon, okay, a cancer which is present in the distal colon, look here. So this is the cancer which is present in the distal colon. What it is doing? So this cancer are going to have the circumferential growth. Okay, there is not an exophytic growth, but a circumferential growth. Circumferential growth is going to be seen. Because of this circumferential growth, now there is going to be obstruction. So obstruction, bowel obstruction. So the bowel is getting narrowed. So proximal cancers are going to present with anemias, and the distal cancers are going to present with obstruction because of circumferential growth. Now see, this is the napkin ring which is used to hold the napkin ring. Now here how the cancer is looking like? The cancer is actually having a circumferential growth. So now here the napkin ring appearance is going to be seen. Okay, a napkin ring appearance. So napkin ring appearance is seen in cancers which are present in distal colon because of the circumferential involvement. Okay, so just once go through this. Right side colon cancers, that is in the ascending colon, tend to grow as large bulky masses. Okay, see, next, they are relatively larger. The ascending colon is going to have a relatively larger caliber. They are more likely to bleed, the cancers in the ascending colon, and therefore more likely to cause iron deficiency anemia. But in contrast, opposite, left sided tumors that is present in the descending colon are the tumors which are present in the rectosigmoid region. Okay, in the rectum and sigmoid colon, tend to be small. They are smaller. They often show infiltration into the wall of the colon, circumferential growth, encircling it and narrowing the lumen. Therefore they are more likely to cause obstruction. So these patients are going to have, okay, the patients are generally going to have the altered bowel movements, altered bowel habits. Okay, because of this obstruction, there is an obstruction, right? So bowel distension will occur, nausea and vomiting can be seen. Okay, so what are the microscopic findings? What kind of microscopic findings can be seen, sir? Look, see, On histology, the most common cancer is what? Adenocarcinoma, right? Whether it is present in the ascending colon or descending colon doesn't matter. It's a adenocarcinoma. So, because of that, you can see the cells are looking like signet ring cells. These are looking like rings, right? There is a big vacuole. There is a big vacuole. Now, these cells are looking like rings. Okay, they are looking like rings because of a large mucinous vacuole which is present in the cytoplasm. See how beautiful it is looking like. It's looking like a cell. Sorry, it's looking like a ring. It's looking like a ring because the nucleus is pushed into the periphery. Now there is a large mucin filled vacuole that is present. So on histology, what you can see is the presence of mucin which pushes the nucleus to one side, giving the signet ring appearance. On radiology, what you will see is, especially if the cancer is present in the rectosigmoid region. Okay, on the left side, I have said you there is going to be a bowel obstruction. Circumferential growth is going to cause bowel obstruction. So whenever you do the barium studies, see here is a contrast, everywhere the contrast is okay. But when the contrast is coming to this region, see the bowel obstruction, the bowel is narrowed. Okay, there is bowel obstruction. So that is giving apple core appearance. Okay, apple core appearance. Okay, now it's looking like an apple core. See here the proximal parts are dilated and here there is narrowed region, right? Here also same. There is narrowing of the bowel because of the circumferential growth. Okay, so this is the important point which I want you to know. Now, look at this question. Look, a 65-year-old woman has had several months of progressive fatigue. From several months she is having progressive fatigue. Diminished appetite, she is not having proper appetite. And unintentional weight loss, she is having weight loss. So, all these, see, old fellow, like an old woman with fatigue, diminished appetite, no, like cachexia symptoms are there and she is losing weight. So, we can always suspect there is a cancer. Old age increase the risk of colon cancer. Okay, the patient has no chronic medical conditions. No chronic medical conditions are seen. She has not received medical care in many years and has not recommended any cancer screening. She hasn't gone through any cancer screening. Okay, cervical screening, like breast screening, like the colon screening, nothing have done. The patient suddenly dies. While undergoing evaluation, while you doing the evaluation, autopsy reveals abnormal large liver findings. Now she is having a large liver. Okay, see, look here. Now what you are seeing here is, sir, there are multiple nodular things that are appreciated in the multiple places. In the multiple places, there are these growths present. So what are these, sir? These are all the cancer metastasis to the lung. Whenever you see multiple nodules that are happening in the lung, which means it indicates that the patient is having some cancer and that cancer is coming to the lung. Do you know what is this cancer? It's a colon cancer. So the colon cancer, the most common site of metastasis. The most common site of metastasis for colon cancer is going to be liver. Okay, the liver is the most common site for the metastasis. So this patient actually is having a colon cancer. She haven't gone any screening. That colon cancer stage 1, 2, 3, 4. Now there is metastasis. Now do you know, from the colon directly via the portal veins. Okay, directly via the portal veins, the cancer will come into the liver. Okay, directly via the portal veins, the cancer will come into the liver. Okay. So what the question they have asked? Microscopic evaluation of the lesions reveal neoplastic cells. Okay, which of the following is most likely cause of patient liver lesions? What is the most likely cause? Lymphatic spread, malignancy metastasizing via the hepatic veins, malignancy spreading through the portal circulation, primary neoplastic transformation of the hepatocytes, transcelomic spread. See, it's a colon cancer. So colon cancer spreads via the portal circulation directly, say, from your intestine. Just generally speaking, just from your intestine. It's the portal veins, right? It's the portal veins bring the blood to the liver for detoxification. So now she is having a colon cancer. Now this colon cancer via the portal veins will come into the liver. And in the liver, see, they are getting deposited in multiple places and there is a liver cancer. Okay. So usually liver have two blood supplies. Okay. One is portal circulation and other is the hepatic artery that is bringing the blood. So two blood supplies are there. There is more chance that these cancers can come into the liver. So now she is having liver cancer and she did. Primary site is colon cancer and she have also developed the mets in the liver. With this, the important topics, the important things which you should know regarding the colon cancer, the risk factors, the types of cancer, the clinical features, the microscopic features, that everything is done. So with this, the topic is completed. Hope the video is helpful. Thank you.